Good afternoon, everyone. Today we'll be seeing about pressure ulcer. So we'll be going through the definition and stages of pressure ulcer, the mechanism of injury, like how the pressure ulcer is caused, and the examination and the differential diagnosis, treatment, and last prevention. So pressure ulcer, like any other ulcer, in simple terms, it's just a discontinuity of the epithelial surface. According to guidelines, in detail, a pressure ulcer can be defined as a lesion localized to the skin and/or to the underlying layers, generally in correspondence with the prominence. This prominence might be a bony prominence as a result of pressure or pressure in combination with the friction and/or shear forces. This definition is given by European Pressure Ulcer Advisory Panel. These are all the sister organizations. These three organizations together frame the guidelines for most of the guidelines for based on pressure ulcer. The other two organizations are the National Pressure Injury Advisory Panel. It is active in the United States. Uh, in the Asian region, the Pan-Pacific Pressure Injury Alliance is there. Coming to the epidemiology of pressure ulcers, it's actually difficult to obtain a uniform result from all the studies because the methodologies differ from one thing to the other, and the denominators and the numerators differ. So there can't. It's difficult to get a uniform thing. So this thing is based on D cube ICU studies. The overall prevalence of pressure ulcer in ICU is 26.6 percentage. In that, 16.2 percentage of pressure ulcers are ICU acquired. Um, as the grade of the ulcer or the stage of the ulcer increases, there is increased mortality, and the factors which affect the pressure ulcer in ICU or the old age, male 6, underweight, increased SAPS-2 score, and Braden score less than 90, and ICU stay greater than 3 days. This DCube ICU study, it's conducted in over 90 countries uh, with around 13,000 sample size. Uh, just a small question, like what do you think is the most common area to develop pressure ulcer in adults? Just can anyone answer? It's actually the sacral region is the most common site to develop pressure ulcer. It's closely followed by heel. So staging as per the National Pressure Injury Alliance program. Stage 1, there will be intact skin with a non-blanchable erythema. In dark skin people, it will be difficult to stage this one, but generally the color will be different from the surrounding in dark skin people. In stage 2, there will be partial thickness loss of the epidermis, leading to a shallow ulcer. Even open and intact blisters come under stage 2. This has to be differentiated from maceration, excoriation, perineal dermatitis, and denudement. Stage 3 and 4 are full thickness tissue loss. In stage 3, the subcutaneous fat is mostly involved, but there won't be any involvement of bone, tendon, or muscle. In contrast, in stage 4, the bone, tendon, or muscle will be exposed or palpable. In addition, it also may contain slough or eschar. In some cases, osteomyelitis might also be present in stage 4. One thing to note is that stage 3 and 4 don't necessarily mean the depth will be more always. In regions such as occipital region or heel or malleolus, the depth might be less since subcutaneous fat will be less there. So you have to define these stages based on the involvement of bone, tendon, or muscle. In addition to these four main stages, two other things are also defined in the guidelines. One is the suspected deep tissue injury. It's also called ICU hyperemia. In this, there will be blanchable redness. The tissue area will be slightly different from the adjacent areas. The importance lies in that this deep tissue injury may herald other stages. Like if it's not attended to, later it can develop to stage 1 or 2. And in full thickness tissue loss, if the base is covered by slough or eschar, it is called an it is termed as unstageable because we can't like actually measure the whole depth, so it's unstageable. Yeah, one thing to note here is that suppose the wound is stable and it is also covered by eschar, we shouldn't disturb the eschar as such if it's stable wound. It acts as a natural cover. So now we will come to the underlying mechanism of pressure ulcers. The basic thing is that the arterial capillary pressure ranges from 30 to 32 millimeters of mercury. When the tissue pressure exceeds this capillary pressure, there will be a loss of blood flow, which in turn causes ischemia and necrosis. The other underlying causes of pressure ulcer mechanism are friction, shear forces, moisture, malnutrition, and immobility. In normal people say like you and me, you and I, if you are lying in the same position for a very prolonged period due to ischemia or due to ischemia, we will feel some discomfort or pain. So as a kind of a reflex, we will be adjusting our position so that we won't be lying in the same position. Like it doesn't happen consciously, subconsciously it happens. So we may not be aware of it. But in people with some neurological conditions such as stroke, transverse myelitis, or decreased sensory perception, they might not be aware of that. So they will be lying in the same position for a prolonged period, which in turn causes pressure ulcer. Malnutrition in upcoming slides we will discuss. One thing to note about people interchangeably use friction and shear forces, but they are like completely different. The friction acts on the surface, whereas the shear forces act deep. Example, like if a patient is lying supine with a head and elevation of 30 degrees, the bed sheet causes friction on his skin. The shear forces means that due to gravity he will be pulled down, whereas due to the bed sheet the friction will be acting slightly opposite direction to the gravity. Due to this internal opposing forces, the shear forces act. The importance lies in that the friction causes superficial wound, whereas the shear forces cause deep wound. A little bit of physics here. So pressure is given by the formula force by area. So if there is a constant, if the force is constant, pressure will be indirectly proportional to area. An example, like say your food is getting stepped on by an elephant with a force of 10 kg. Since the area over it acts is more, it will be less painful compared to the same force acted upon by the heel of a woman with the same force, say 10 kg. I don't intend to say that like girls cause more pain than elephant. So, and another thing is like pressure is directly proportional to time. This thing. You had a side. Yeah. So the second term, pressure is directly proportional to time. So this is a picture of from a film Badri active starring Tamil actor Vijay. So in this particular scene, cars will be moving over the dorsum of his hand. It will hardly have a contact period of 2 to 3 seconds, so it won't be that much painful. If the car stays in the same position for more than like 30 seconds, it will cause more pressure and hence it will be more painful. Um, Coming to the examination part, like any other ulcer, the pressure ulcer also like it has to be examined as a normal ulcer. In history, you will be asking about the mode of onset, the duration, pain, discharge, and any associated conditions. Like I told, the neurological conditions. In inspection, we will be seeing the size, shape, and number. It will be helpful if we have a photographic evidence. So over a period of time, there won't be observe variability, and also the position, edge, floor, and the surrounding area has to be inspected. In palpation, we'll be looking for tenderness. Say if the wound is infected, this can be found out. And margin, base, depth, and the bleeding has to be seen in palpation. A little bit of insight here. People often confuse between margin, edge, floor, and base. Margin is actually the border of the ulcer. So in this cliff, you can see the border. The edge is the sloping, the slope of the ulcer that is in the side. The edge lies between the floor and the margin. The floor is what you see and the base is what the ulcer lies on. Coming to the differential diagnosis, you have to differentiate the pressure ulcers from other ulcers. The malignant ulcers, they will have systemic cachexia and systemic symptoms, as well as it might bleed on touch. Tuberculous ulcers will have undermining edge, and lymph node enlargement will also be there. Diabetic ulcers, the patients will have diabetes, and venous ulcers, it will be more specific to gutters area or the medial malleolus. Similarly, diabetic ulcer will also be more commonly found near foot. So based on the site and the other symptoms, we can differentiate pressure ulcer from the other ulcers. One important entity to be noted here is incontinence associated dermatitis, or IAD. People often confuse between these two. In incontinence associated dermatitis, urine or fecal incontinence will be there, which causes an increased pH and increased microbial environment. And the urea and ammonia produced in these urine and feces, they cause irritation of the skin. This irritation, which in turn causes the increased permeability of the skin, it decreases the barrier function of the skin, and it helps the bacteria to invade, and thus it gets infected. This is incontinence associated dermatitis. The risk assessment: how to know if a person is at risk of developing a pressure ulcer. There are various scales. The first scale was found, which was used for this purpose, is the Norton scale. Gradually, the Gosnell scale, Waterloo scale, and the Cubbin and Jackson scale. It's kind of specific to the critical care patients, but the Braden scale is the most widely used. Even in our ICU, we use the Braden scale. I have kept these Bradma and the director there, like you can just circulate there. So this Braden scale, it has different parameters which are scored from 1 to 4. The different parameters are sensory perception, moisture, activity, mobility, nutrition, and friction and shear forces. So the total score, if it's like a minimum, if it's less than 15, if it's greater than 15, it's minimal risk. So if there is just minimal risk, the nurses, they will reassess every day, every 24 hours, they will reassess if there is minimal risk. In addition, they will follow the normal skin care, keeping the skin dry and moisturizing it, as well as changing the position from time to time. And the bony prominences have to be safe pads can be kept in the bony prominences. One cheap alternative would be using water gloves. Even in our ICU, we use the water gloves to protect the bony surfaces. And even if you are using some medical equipment, say arterial line, to keep it in position, we will be using what do you call? You will be using this splint. Sorry, I will be using the splint. If the splint, if it stays in the same position for a prolonged period, it can also cause pressure ulcer. So you have to be mindful of that too. When there is moderate risk, in addition to all these things, the nurses will reassess the patient in each shift. They will reassess the patient and they will reposition the patient every 2 hours. At last, when there is high risk, they will re-examine the patient every 2 hours when they reposition, and all other things also has to be followed. So coming to the treatment part, we have nutritional support, dressings, negative pressure wound therapy, surgical procedures, and adjunctive therapies. Pressure ulcer management, it has to be a multimodal approach. A multimodal approach has to be taken to pressure ulcers. Coming to the nutrition plays a big part in pressure ulcer. It say a patient has an acute stress or has an acute or chronic disease, it results in poor nutritional status. He'll have low BMI, weight loss, or decreased food intake. This in turn predisposes to pressure ulcer. The pressure ulcer is essentially an inflammatory process which results in catabolism. Due to this inflammatory process, as well as the exudate, there will be loss of nutrients, which results in protein calorie malnutrition. All these things will end in a vicious cycle. So it's essential that we stop wherever needed. Like we have to stop this malnutrition thing. There are nutritional recommendations by the given in the guidelines. It advocates 30 to 35 kilocalories per kilogram kilocalories has to be taken per day. And if the nutrition requirements of a patient is not met through his normal intake, we can offer fortified foods. And if the patient is not able to take orally, we can resort to other modes like NG tube feeding or nasojejunal feeding, as well as total parenteral nutrition. A positive nitrogen balance has to be maintained with ideally 1.25 to 1.5 gram of protein per kg intake has to be there. And recent studies advocate that arginine, zinc, and antioxidants, along with the all other approaches, multimodal approach, has a positive impact on wound healing. Adequate hydration has to be maintained, and if there are vitamin and mineral deficiencies, it can also be supplemented. Coming next to the dressings, different types of dressings are there, namely alginate dressings, collagen dressings, gelling fiber dressings, polyacrylate dressings. The different dressings vary in their mechanism of action. We will briefly look upon some of the dressings. If there is a necrotic tissue, enzymatic debridement will be there, followed by hydrocolloid dressing. This hydrocolloid dressing essentially absorbs the exudate which comes from this enzymatic debridement. If there is moderate to high exudate, we can use alginate dressings, gelling fiber dressings, and polyurethane foams. These alginate dressings, they are made from seaweeds or algae. The gelling fiber dressings are made from carboxymethyl cellulose, and polyurethane foam has polyurethane. These things have a highly absorbable surface, so the moderate to high exudate will be absorbed by those dressings. In case of infection, we can use dressings which contain stuff from chlorhexidine dressing to silver containing dressings to even antimicrobial dressings which contain antibiotics. On wound closure management, recently these dermal matrix dressings or the collagen based dressing have come into action. Like these things, they decrease the matrix metalloproteinase activity, as well as they will provide a scaffolding over which the wound healing can occur. The choice of dressing depends on three factors: the choice of the clinician, the patient's wish, as well as the resource availability. Negative pressure wound therapy. The negative pressure wound therapy is a controlled application of subatmospheric pressure, which in turn promotes wound healing by secondary or tertiary intention. A secondary intention means when the wound will close by the formation of granulation tissue. In tertiary intention, after the formation of granulation tissue, we will put a suture and approximate the wounds. There are only a few contraindications for negative pressure wound therapy, such as malignancy, untreated osteomyelitis, fistulas, necrotic tissue with eschar, and we should not apply this NPWT over blood vessels, nerves, and anastomotic sites. In these instances, it causes more harm than actual benefits. This NPWT is actually used in stage 3 and 4 ulcers. Actually, we use the term VAC very commonly. We are using VAC therapy, VAC dressing, but it is actually a patented thing. It's not a generic thing. The generic name is negative pressure wound therapy. Surgical part comprises of two things. One is wound bed preparation through debridement. Then would be in this debridement, there are different types of debridements. One is the autolytic debridement. It naturally occurs in the wound through lysosomal enzymes which are present in the exudate. The enzymatic debridement, we use exogenous lytic enzymes such as collagenases to cause this debridement. In mechanical debridement, through the friction of the gauze which we use, the debridement process happens. And another thing is the biological debridement. The fly larvae are bred in sterile conditions and they are put in the wound. They will eat upon this slough and it will act as a debridement procedure. The surgical debridement we are aware of it, like the surgical colleagues, they might using shafts, they will form a clean wound site and then they will proceed from there. Even this negative pressure wound therapy comes under this technological debridement, and also other technological debridements are hydrosurgery and increased frequency ultrasound. The surgical procedure, as I told first, we will be using the debridement or the removal of the ulcer as such. Then if there are any bones jutting out, bony prominence is there, or the bones are infected, through osteotomy we will remove those bones. see if you are close approximating the wound and it's getting healed, but you are not removing the sores, like if the bone is out, the ulcer will recur. So there osteotomy comes into play. And after this is done, we will come to this reconstruction. Through reconstruction, we will try to achieve what was the normal thing before. If it's a small wound, we will use direct closure technique. If it's a big wound, we will use either grafts or flaps. The difference between grafts and flaps is that in flaps, we'll have a blood supply specific to the flap. The different types of flaps used in plastic surgery are the fasciocutaneous flaps, myocutaneous flaps, muscle flaps, and perforated flaps. And adjunctive therapies, these are recently used. Out of all these adjunctive therapies, electrical stimulation has the more evidence of positive impact on wound healing. In this electrical stimulation, we will connect the cathode, the negative terminal over the wound, and the anode or the positive terminal would be connected someplace proximal to the wound. And through this electrical stimulation, there will be a change in the microclimate of the wound. That's how the wound healing occurs. This laser therapy, extracorporeal shockwave therapy, and topical oxygen therapy, they are newer therapies. They are more evidence has to be obtained on them. So coming to the prevention of pressure ulcer, we are mostly concentrated on the how the pressure ulcer affects the patient's condition in the ICU, but we won't be thinking about the psychological impact it has on the patient. Even if the patient has a pressure ulcer, it can go to such an extent there where they can be ostracized due to these smell from the pressure ulcer as well as the unsightliness. So the term better safe than sorry will be more relevant in pressure ulcer. So this EPUAP and as well as the National Pressure Ulcer Advisory Panel, they are promoting this Stop Pressure Ulcer Day. It is connected on every third Thursday of November to educate the public and the policy makers. We often use the term bed sores, but this is a layman term, and it also like undermines the pressure ulcer burden in the society. So it's better to use the term pressure ulcer instead of bed sores. This is the logo of the Stop Pressure Ulcer Day, and these are some of the mementos which are used for the Pressure Ulcer Day. And I have used resources from the guidelines from the sister organizations, Schwartz, Sebastian, Bailey and Lowe surgical books, DAS for the examination. And there is a book called Science and Practice of Pressure Ulcer Management. It's actually 230 pages, is actually quite good. Like recent advances, everything they had given in nice format. And one study for the epidemiology I had taken, DCube ICU study. Thank you.